So let's move on about what about complications of diabetes? We notice the same pathophysiological mechanisms that damage the beta cell, genes, environment, insulin resistance, inflammation, are also involved in the risk of developing all the complications of diabetes, the traditional micro and macrovascular complications. And you can see that here. On the left is what we presented before, leads to destruction and influences, reduces beta cell function, diminished insulin secretion of beta cell mass, cell damage, dysfunction, increased intracellular fuel excess affects the beta cells. But the same processes on the left have been shown to contribute to adverse impact on the cells related to diabetes complications, eye, kidney, nerve disease. And we're not talking about micro and macrovascular. It's affecting the cells and their tissues. It's not purely the vessels. And you should remember, even though it's not well discerned in the literature, that the same complications for type 1 are the same complications that exist for type 2. You should also see on the lower right that when you affect the beta cells, you are causing extracellular fuel excess, glucolipotoxicity, and these have further damage on the cells related to the diabetic complications. This is a picture of how gene-environment interactions with diabetes and its complications. So you can see type 2 diabetes and environmental factors will relate to the risk of coronary artery disease, obesity, diabetic neuropathy, and DN could also stand for nephropathy, and diabetic retinopathy. So these overlapping genes that cause diabetes overlap with the genes that affect the risk of these other complications. And the mechanism of cell damage in diabetes is intracellular fuel excess, and that's well described by Brownlee's hypotheses for pathways, PKC pathway, hexokinase, advanced glycosylation end products, sorbitol pathway, which will then create reactive oxygen species, induction of transcription factors, inflammation, and affect gene expression, epigenetic changes that we discussed before in susceptible cell types and tissues. These include the worsening beta cell function, as well as the cells and tissues related to all the complications of diabetes, eye, kidney, nerve, heart disease, cancer, dementia, NASH, psoriasis. I'll go further in that regard in a moment. And these epigenetic gene expression changes are exacerbated by insulin resistance, metabolic syndrome, inflammation, immune system, environmental interactions. And the change in gene expression is affected by the same processes. And these effects from Brownlee's adverse increased flux through those pathways will result in mass increasing amounts of metabolic redox regulators, microRNAs, and multiple other markers. Here's a story, again, epigenetic changes. Oops. Let's go backwards. The epigenetic changes will cause complications, well described. Even glycemic fluctuations seen in prediabetes can affect these tissues. And epigenetic changes that can cause complications, the good news may be preventable and even reversible. And I'm not going to go through details in these basic science articles, but they show that epigenetic changes can be preventable, can be reversed. Now, markers then can become the method to implement precision medicine of diabetes. And you can get markers for epigenetic changes, marker for environment, inflammation, insulin resistance. You get markers for damage to the eye, kidney, nerve, and other cells and tissues, markers for abnormal beta cell function. For example, mRNA markers exist in nephropathy, retinopathy, neuropathy, and some of them overlap with each other. You can get mRNAs that have been shown to be related to insulin secretion and insulin sensitivity. And we need a compendium of markers because you can see here that there are lots of pathways that relate to markers for diabetes. These are in black boxes, and markers for diabetes for these pathways that affect the risk of heart disease. And eventually you're going to need to get agreement among experts in the field of which best markers to use for assessing complications as well as assessing the risk for diabetes and progression of diabetes. And then the next paper we published was that there are some conditions we noticed that are associated with diabetes by epidemiology: heart disease, vascular disease, psoriasis, cancer, NASH, and dementia. You can see here on the upper left, psoriasis by epidemiology, the epidemiology of coronary heart disease risk, epidemiology of cancer and diabetes, epidemiology of dementia, and then epidemiology of NASH, all related to diabetes. But then we noticed that the same pathophysiological mechanisms that damage the beta cell, genes, environment, insulin resistance, inflammation, are in fact involved in the risk of developing all the usual complications of diabetes, but they're also involved in these conditions that we've just discussed. Shouldn't we then call a vascular disease, psoriasis, cancer, NASH, dementia as, quote, diabetes complications? Specifically, we noticed the same genes that cause diabetes also are related to the complications of diabetes, the eye, kidney, nerve, but also these other factors: heart, psoriasis, NASH, cancers, and dementia. And you can see that here, upper left is psoriasis, NASH in the middle, cancer genes, environmental genes, and overlap with the classic microvascular complications, but we should call them eye, kidney, nerve disease, overlap with the diabetes genes, and then overlapping dementia and diabetes genes as well. And then these next couple of slides show that in different areas, this first one up on the left is NASH. You can see that the genes and environment, inflammation, and also insulin resistance are the same factors that cause other complications of diabetes itself are related to NASH. Cancer, genes, environment, insulin resistance, inflammation related to cancer. Over here, psoriasis, genes, insulin resistance, inflammation, environmental factors related to the obesity and so forth, related to complications of psoriasis. And here you have insulin resistance, environment, hypertension, genetics, and inflammation is in here related to cardiovascular risk. And by the way, these factors here exist and can help explain why some people get complications and some people don't, and some people get greater or lesser risk of these issues. Here, metabolic disorder affects the risk of getting complications by individual susceptibility. Here's your genetic story as well as your epigenetic story. And modulating factors, hypertension, smoking, inflammation, insulin resistance, affect the risk of complications. Early changes are reversible, late changes are not. And the dementia has the same issues of insulin resistance, gene environment interactions, inflammation. So that caused me to publish the paper. That's the title of this webinar. Let's redefine complications of diabetes as diabetes specific, retinopathy, neuropathy, nephropathy, but also associated conditions, heart, cancer, dementia, psoriasis, NASH's complications. And let's call this whole compendium of processes and outcomes as the diabetes syndrome. And these complications and conditions are the same whether you have, quote, classic type 1 or type 2 diabetes, or what I call all diabetes. And I created this picture, and this is just a picture of the environment story, genes affecting its resistance, affecting the inflammation, beta cell dysfunction, this resistance affected by your metabolic syndrome, hypertension, lipids, obesity, insulin resistance. And these all lead to now what I'm calling the diabetes syndrome, the traditional complications of diabetes, as well as cancer, dementia, psoriasis, heart disease, and lipids. And I illustrate that there are markers for each of these that'll help us eventually pick the right drugs for the right patients. So we submit that the diabetes syndrome then becomes more than a name, because classification and nomenclature has purpose and function. It can lead to the concepts of precision medicine. And you can see how this could work. You can take EMR data on top, combine it with OMIC data, and now there's new single cell OMIC plots available. And this will end up allowing the computer to do dynamic decision support, put these all together and come out with recommendations as you're on the page with your current patient, which is and lead to recommendations of therapy. This is artificial intelligence for medicine. And it's a potential solution for efficient quality treatment for huge populations. I was in China 4 times in the past few years, and they're all looking for ways of defining the best therapy for each individual patient, because the doctors don't have a lot of time to spend with each individual patient. The computer, the dynamic decision support, AI will provide this for them. And the specific markers, we can bold ones that will work for each individual patient, that the computer is doing this and lead to the best therapy. Review briefly genetic story. That is, phenotype is dependent on the genotype, which are the number of genes, which genes, the nature of the genes, how many different ones, severity and intensity of expression. Epigenetics we discussed, how the genes affect beta cell function, secretory dynamics, sites of susceptibility to beta cell destruction by endogenous and exogenous triggers, immune modulation, inflammation, insulin resistance, environment, susceptibility to the viruses and food AGEs and pharmacogenetics, and the susceptibility to diabetic complications. And these genes overlap for the typical complications, and the genes overlap for these other processes, cancer, dementia, heart disease, psoriasis, and NASH. And summarize the beta cell, we can use the usual glycemic criteria, glycohemoglobin, fasting sugar, postprandial glucose, but I do recommend changing the diagnosis diabetes down to the pre-diabetic levels. We can use classic markers, C-peptide, ISL antibodies, but you're going to see there's going to be new non-invasive markers for beta cell mass, circulating DNA markers of beta cell destruction. Glasser at Hebrew University is doing these, circulating microRNAs, non-coding RNAs, and now this single cell omics plot. And I emphasize there's no logic for the use of agents that may contribute to apoptosis of the beta cell. Stop using glinides, use sulfonylureas. Let's minimize insulin therapy, preserve beta cell function. Immunology, I'll review briefly here. We say the innate and adaptive immunity for type 1 and type 2. Obesity increases anti-islet cell cytokines, and inflammation. Gut microbiota do the same thing. Inflammation and cancer in more detail. So these are really ubiquitous process in diabetes, its complications and associated conditions, i.e. the diabetes syndrome. And the good news in terms of the inflammation story is that you'll be seeing, and there are existing therapies for immunity. There are exploratory articles on using anti-CD20 drugs, anti-CD3 drugs, CTLA, 4LG, abatacept, and other kinds of therapies. On the right, you'll see that even the drugs we're using have anti-inflammatory processes such as TZDs, metformin, GLP-1 receptor agonists, DPP4s, SGLT2s, stories from DPP4s and vitamin D. We can use these processes, these drugs, which are treating diabetes, to also reduce the risk of some of the complications, atherosclerotic issues, as well as some of the other conditions we've discussed. Even now, SGLT2s have been shown to be part of this process. And we reviewed resistance before and environment before, so we'll not review those now. So the value of our construct is it explains why similar glycohemoglobin in different folk give different risks. It understands how diabetes medicines reduce cardiovascular outcomes. Even if the glycemic benefit is small, you may get reductions in damage to the beta cell, and these reduce the risk of these other processes, including cancer, dementia, psoriasis, NASH, heart disease. And in drug design, we can take advantage of multiple benefits of anti-diabetic agents and repurpose old medicines. You can see in UK-PDS DCCT, you had benefits with glycohemoglobin drop on eye, kidney, nerve disease. In UK-PDS, heart disease, all-cause mortality. But in some of the secondary studies, the ADT advanced trials and the core trial, there were not such reductions in risk, but we believe in that regard, the glycemic benefit could not be proven in the face of metabolic memory. There had been previous damage to tissues, which starts in prediabetes, by the way, as well as using the wrong drugs. For example, the sulfonylureas, wrong processes of care. The good news in yellow, that bromocriptine quick release, the SGLT2s, pioglitazone in the IRIS trial, GLP-1 receptor agonist, now seem to have benefits in not only glycemic benefits, but in improving outcomes of these other conditions associated with diabetes. And there are crosstalk benefits of current and which we reviewed medicines and future medicines. So age inhibitors and K activators, biglanides, TZDs, GLP-1s, DPP-4s, SGLT2s, antioxidants, TNF-alpha, inflammasomes, PKC inhibitors, VEGF inhibitors, PARP inhibitors. These will affect metabolic tissues, endothelium, macrophages. We just need some more studies. The current drugs are in blue and the future in red, and we will get benefits not only in the diabetes care, but in these other associated conditions reduction, which, by the way, provides a major logic for my proposal to switch down to diagnosis of diabetes at pre-diabetic levels, because by treating drugs that are treating sugar as well as these other factors, these other factor benefits make it cost effective to start therapies earlier than later. So these are the data that exists now for the current medicines. You'll see I put the abatacept, ibuprofen, as well as the current medicines we're using that have benefits across all these quote complications in the diabetes syndrome.